Hello, welcome to the session all about paraneoplastic cerebellar degeneration. It is my privilege to introduce both of our speakers today. So we don't have one, but we have two experts on this form of ataxia. So first off, we have Dr. Justin Abbatemarco, who is an assistant professor at the Cleveland Clinic Lerner College of Medicine and a staff physician at the Mellen Center. He graduated from the Cleveland Clinic. He is a dual fellow trained in neuroimmunology at the Cleveland Clinic and the Mellen Center and autoimmunology from the University of Utah. And second, we have Dr. Elizabeth Page, who is a current resident physician at the Cleveland Clinic Neurology residency program and has a professional interest in neuroimmunology. She's completed her medical education at the Ohio State University College of Medicine. And with that, Dr. Page, Dr. Abbatemarco, the floor is yours.
Absolutely a privilege to speak to you all today. We appreciate you taking the time to be here and learn from us today. We're kind of going back and forth, and I'll at some point pass the baton to Dr. Abbatemarco to talk a little bit more about treatment landscapes for this disorder. But I wanted to give you a brief overview of kind of how the day is going to look, with plenty of time for questions at the end. So most of you are familiar with kind of basic definitions of ataxia, as well as the disease mechanisms behind the autoimmune piece of cerebellar ataxia. But I wanted to specifically talk about paraneoplastic diseases and what that looks like, the associated cancer syndromes and paraneoplastic diseases, the history of how we came to understand paraneoplastic diseases and the relationship between cancer diagnoses and some of these paraneoplastic diseases. I want to give you a couple of cases of patients that we've seen or that we've known about, and how their clinical course has looked, what treatment looked like for them, and how recovery has looked. And in that, highlighting some points that you all may come across in your own journeys about diagnosis and management, as well as kind of the steps to obtaining this diagnosis or going through treatment and what that looks like as a patient as well. I wanted to highlight some treatment landscapes for kind of the neuroimmunology piece of treatment for these disorders. Of course, with paraneoplastic diseases, we rely a lot on oncology treatment, but at least what we know about neuroimmunology and the autoimmune piece, what that treatment landscape looks like, and then passing over to Dr. Abbatemarco to talk about clinical trials in this area or in adjacent fields that we may be able to translate to paraneoplastic diseases. I wanted to end with a little bit of, hope and some interesting, stories that we've seen here at our Mellen Center of how we can use technology and physical therapy to really advance people's recovery. And then, of course, we wanted to give you all plenty of time for questions, since, that's why we're all here. So first things first, some definitions of ataxia as well as the history of paraneoplastic cerebellar ataxia. As I'm sure this population is well aware of the definition of ataxia, but I just wanted to highlight for everybody, ataxia can take in a number of different symptoms, but overall it describes the lack of muscle coordination. This can be manifest in multiple different ways, whether this is unsteadiness with walking, so this wide gait, whether it's stumbling over your steps, but it can also be unsteadiness with sitting or standing. We can have truncal ataxia, where even with supporting your own head, you can have instability in doing that. People also get symptoms like vertigo or nausea. Sometimes this impaired coordination can affect the hands, the feet. It may even manifest as a tremor for some. And then we can have discoordination of not just the body, but also the eye movements. People can have double vision. They can have nystagmus, which is kind of these jerky, uncontrolled eye movements. And that can cause a lot of visual difficulties and difficulties with function. And then as well, we can see changes with speech and swallowing in our patients with ataxia as well. And here we just have kind of what we look at as neurologists when we look at somebody's gait. Sometimes people with ataxia have a wider gait because they're trying to stabilize themselves with their legs because they're having some more difficulties with coordination. So there's many different causes of ataxia. In at least the neurology realm, we start to think about, what is the onset? Is this something that has taken seconds or minutes to start? In those cases, we think of more common diagnoses like stroke. Other causes of ataxia can be things like nutritional deficiencies or toxicities from either, medications, other vitamins, but that takes on the course of months or even years. Things like MS, genetic conditions, infections, brain masses, anything that affects the central nervous system, of course, can certainly cause ataxia as well. Then we have other things like disorders of the inner ear, cranial nerve 8, which is more of a peripheral condition, which is how we kind of process information about the environment around us, where we are in space, and that can certainly cause ataxia as well. Then I wanted to just highlight that autoimmune conditions and paraneoplastic causes are some of the less common causes of ataxia, but it's important to always keep them on our differential. We have a number of different parts of the nervous system that helps us with coordination. Highlighted here is the cerebellum, and we look at our Purkinje cells, which are helpful in giving us balance. The cerebellum is organized in such a way geographically that we think the edges help us with controlling things like our arms and legs, whereas more in the central part of the cerebellum, we think more of our trunk, our neck. But then those tracks that help us, pass information about balance, they pass all through down the brainstem and down the spinal cord. So injury to any one of those areas can certainly cause ataxia. I want to just give a brief definition of paraneoplastic neurologic syndromes. I know that you all have perhaps heard all about autoimmune neurologic syndromes, and these are somewhat related in that it's all about immune response, but the paraneoplastic syndromes are specific in a way where they're related to cancer. So I find this helpful, not everybody does, but the literal definition of paraneoplastic, para means beside, and neoplastic literally means new growth, but refers to a tumor or cancer. So when we talk about paraneoplastic neurologic syndromes, it's something that is related to an underlying cancer. I wanted to highlight that this is not necessarily, and is in fact by definition, not a cancer that resides within the central nervous system, like a glioma or some of our central nervous system cancers, but something outside, somewhere else in the body. And the idea is that these cancer cells, something about them triggers an exaggerated immune response. And then the immune system is what attacks our healthy nerve cells and can cause a variety of different neurologic syndromes, ataxia being one of them. And then in most of our patients with paraneoplastic neurologic syndromes, it's actually this paraneoplastic neurologic syndrome, perhaps their ataxia, that's their first sign of cancer. Many of these people had no idea that there was a small cancer that laid unidentified, and we only find out kind of on our screening later on down the road. This is just highlighting, how many different parts of the brain and the rest of the body can be affected in these paraneoplastic neurologic syndromes. So when we talk about paraneoplastic cerebellar degeneration, that's just one piece of our paraneoplastic neurologic landscape. Other parts of the brain that are affected can cause different things. So myelitis or confusion can cause seizures. All of these are potential sequelae of our paraneoplastic conditions. But if you see in this very light blue at the back of the cerebellum there, if it affects the cerebellum, then this is what, oh, thank you, Dr. Abbatemarco. This is what we refer to as our paraneoplastic cerebellar degeneration. Not just the central nervous system can affect the eyes, the muscle, the stomach, but I just wanted to highlight really the landscape of this class of diseases is very, very wide. And then I alluded to this earlier, but I wanted to really illustrate how this works. So we have here on the left, we have a primary ovarian cancer. It creates some sort of protein that our immune system recognizes and then creates kind of attacking cells to attack this kind of what is thought to be a foreign invader, but in fact lives in our central nervous system. So it creates these kind of attack immune cells, these CD8 T cells, and this can attack our healthy central nervous system and cause symptoms. Again, this is one of several paraneoplastic syndromes, and it's all about the proteins that are produced by these cancers. Just a quick look at history. What is thought to be our first documented diagnosis of like a paraneoplastic neurologic disorder, a woman presented with aphasia, some other cognitive changes, and within the next week, she had passed, and on autopsy, she was found to have an underlying gastric cancer. So it's possible maybe those two things were related, but we didn't know anything about antibodies or kind of the relationship between those two pieces back then. Then in 1919, we had our first description of a paraneoplastic cerebellar ataxia, and that was found to be associated with ovarian cancer. But it wasn't until the 1980s that we were characterizing some of these antibodies that are really the culprits in these diseases. So things like anti-Yo and ovarian cancer, and we'll go on to describe some more of these antibodies that we see. And then in 2008, we start learning more about other antibodies. We start thinking about autoimmune conditions that are not actually related to an underlying cancer. So we now have this diagnosis of a primary autoimmune cerebellar ataxia that exists without a need to diagnose an underlying cancer. It's the antibodies on their own causing this issue. Just a brief overview, because I know that, we can get bogged down in the details here. So there are several common cancers that we think of when we think of paraneoplastic cerebellar degeneration, one of them being lung cancer, particularly small cell. We think of a couple antibodies, anti-Hu, anti-Re. Those are found in all neurons, not just specifically neurons in the cerebellum. In our gynecologic cancers, mostly ovarian, but can also be ovarian cancers, anti-Yo is found in Purkinje cells in the cerebellum. Breast cancer, we see similar antibodies in this patient population as well, but we also see amphiphysin, which is more of kind of a stiff person's phenotype. And then some of our other cancers like Hodgkin's lymphoma or other blood malignancies can be associated with paraneoplastic cerebellar degeneration as well. I wanted to highlight here, just because this is important for treatment, we have a wide variety of immune-mediated cerebellar ataxias. So something about the immune system attacking the central nervous system and causing this ataxia. And it can either be because there's an external trigger present that's causing the immune system to react to this in this way, or it's something that's just within the body itself. There's no external trigger. There's no way to remove that external trigger necessarily. And so for these cases that have an external trigger present, that's our paraneoplastic causes. The trigger is the cancer. And so if we can focus on eliminating the cancer, the idea is that this ideally will remove the impetus for the immune system to attack the central nervous system. We've also discovered a gluten ataxia, whereas gluten can be that trigger as well. And then that's different than our autoimmune ataxias, in which there isn't an external trigger. It's the immune system itself. So a few things about clinical features. I like to highlight this just so you know kind of what to expect. And I wanted to highlight this with a patient case. So here we had a 33-year-old female. She didn't have any past medical history that was significant. Beginning in fall 2023, she started noticing dizziness, but then very quickly over the next couple weeks, she started having worsening ataxia, issues with gait, walking, was falling more frequently, developed double vision as well, and then finally slurred speech. She came into the hospital and had a lumbar puncture, which showed inflammation. We saw an increased number of white blood cells, and her initial MRI didn't have any abnormalities on it whatsoever. Then we saw an mGlu-R1 antibody, which came positive. With a suspicion of paraneoplastic disease, that triggered a cancer workup. So we obtained a CT of her chest, abdomen, pelvis to look for any cancer. This is not a woman who had a history of cancer that we were aware of, but we did not find anything on this CT scan. So out of an abundance of caution, knowing that this is an antibody that can be associated with paraneoplastic disease, we referred her to hematology. She was discovered to have a lymphoma, and then she was started on chemotherapy. Despite just starting chemotherapy, she still had some ongoing symptoms. So she was put on some IVIG to give her some support to her immune system to kind of relax the immune system, try to reduce some of that immune response and improve her symptoms. She had some clinical improvement with both the cancer treatment and the IVIG, but I want to highlight that it's really the cancer treatment that's treating the paraneoplastic disease, and the IVIG was for support. And she's planning on starting a family in July, so we're planning on weaning both of those things as well now that she's entering into remission. A few other things, she had some persistent weakness of her throat, swallowing continued to be difficult. So we referred her to sleep medicine because they also mentioned that she was having increased snoring at night. She was found to have sleep apnea, started on a CPAP, started to feel much better in the mornings, fewer headaches, better management of fatigue as well. And then this particular patient did really well. She was following with vestibular rehabilitation, responding very well, ambulating independently now, and she's actually graduating from PT likely this summer. A few things highlighting from this case here that is typical for a paraneoplastic cerebellar degeneration case. So her imbalance developed over the course of weeks. Some folks have preceding nausea or vomiting. Her CSF studies, when we did a lumbar puncture, showed inflammation with her increased white blood cells. Some other patients have increased protein as well. When we talk about the definite diagnosis of paraneoplastic disease, we want to confirm a presence of a cancer, which differentiates this from just an autoimmune disease. But you can also, there are well-defined antibodies that are associated with these diseases. So if these appear, then we can confirm the diagnosis as well. And like I said, I really just wanted to highlight that, again, her symptoms, her dizziness, her troubles with gait, those were the first manifestations of any of her cancer. None of her initial screening demonstrated this. So it's really important to be very suspicious for an underlying cancer in this patient population. Just a couple quick details about mGlu-R1. I don't want to, go over this in too much detail, but this can be both a paraneoplastic or a non-paraneoplastic cerebellar cause of cerebellar ataxia. Initially, oftentimes we see that the MRI is normal, but then later on we can see some atrophy of the cerebellum as well. There may be some beneficial effect of immunotherapy in prior studies. Half of patients in one study demonstrated improvement on IVIG in this patient population. Again, so just reiterating those key points, it's important to rule out occult cancer given these strong associations with antibodies. And so our patients need to be retested in regular intervals to make sure that there's nothing that we've missed earlier. Another thing I'll be talking about in a bit is early therapy is important for these patients. So A, identifying that cancer, and B, getting them on some kind of immunotherapy to control the immune response is important for recovery. Similarly, it's important to engage with our therapy team to help with recovery as well. PT, OT, vestibular therapy, speech therapy if needed, to help our patients recover. It's also important to have multidisciplinary care. So working with our PCP, working with specialists, for instance, sleep medicine made a large difference for this patient to make sure that, A, we're doing everything we can with cancer screening, but also addressing any kind of comprehensive care needs. And I also just wanted to highlight that this patient did really well with treatment, with immunotherapy, and with rehabilitation. All of this can seem really overwhelming, and I know that this is a busy slide, but I just wanted to highlight what a team sport managing this disease is. So at the center, of course, is our patient. Then we have our neuroimmunologist who has expertise in autoimmune or paraneoplastic neurologic conditions. And they are kind of a team, and we're referring you out to wherever it is that you need to be seen. So whether that's a neurologic subspecialty, so sleep medicine in this patient's case, but in somebody with disabling tremors, movement disorders is also an important partner for us. In paraneoplastic neurologic conditions outside of cerebellar ataxia, seizures are not uncommon. So having a good relationship with our fellows in epilepsy is also important. And then, of course, this is mentioned a couple of times, but for paraneoplastic diseases, having a very close working relationship with either oncology or neuro-oncology to make sure that we are screening for whatever we need to be, knowledgeable of risk factors, and making sure that we are readdressing this at regular intervals to make sure there's no micrometastases or any other issues that we may be missing, because that could cause recurrence of the disease. Some additional services that we have, cognition or cognitive changes, mood changes are very often comorbid in this disease. So we want to make sure that patients who need support from our psychologist or neuropsychologist or a psychiatrist have that support as well. And so that's an ongoing conversation. Every time somebody comes into clinic, we make sure that we're addressing mood, of course. Similarly, rehabilitation is just as important as treatment. So making sure that our patients have a good relationship and are regularly seeing their physical and occupational therapists, as well as physiatrists if they need any help with spasticity. So I know that's a lot. I just wanted to really reiterate that this is a team sport, and we're all trying to work together to provide the best patient care. So this is one, I think, frustration that comes up in clinic often, and it's understandable, is you may feel that, week to week, you may feel you're worse this week than you were that week, or that, there have been multiple step backs over the course of your journey. Whereas the hope is that, it's just a linear progression forward. You continue to improve day after day. Every day that comes is you're feeling better and can do more. But reality is that it feels very messy, and that, maybe you've made a lot of progress backwards. But I want to give people hope a little bit and talk about what I think our expectations should be. And that, there may be some, modulations day to day. There may be good weeks, there may be bad weeks, but I want people to look forward towards the goal of recovery, you know, doing more as much as we can with our independence, getting around, working together to work towards this end goal, regardless of if there's been a bad day or a bad week. Really looking back 6 months from now, how did things look? Were they better or worse? Are we making progress towards that goal? So I think that's my hope, is to give people hope and looking towards the future. A couple things that I really wanted to highlight here is empathizing with the experience from you. I know you all hear from a number of physicians on this, but I don't think we talk about what you experience as patients going through all of this. So of course you'll be asked about all kinds of symptoms, but specifically what we're interested in is asking about balance, vision, any kinds of tremor, coordination, or speech problems. Sometimes if you know that you've had a preceding illness, if you've had a prior cancer, or if you have any kind of genetic cancer, something that runs in your family, this can be very useful for us if you're able to share that with your clinician. Similarly, whether you've had a prior workup or if you're presenting for the first time, it's important for us to get an MRI of the brain in order to look for any existing inflammation or atrophy. This may or may not include the spine, depending on what your neurologist is concerned about. If they think that there might be some spinal cord involvement, they may obtain that as well. Lumbar puncture is also very important, both to look for antibodies, but also to look for signs of inflammation in the CSF. And I'll talk a little bit more about that in the future. Blood tests, again, we can look for antibodies or other causes of ataxia too. And then if we're suspicious for seizures, sometimes we will ask that patients undergo an EEG or a test that looks at the brain waves looking for seizures. If we're very suspicious of a paraneoplastic process, then oftentimes we will do an initial cancer screening, which can involve a CT of the abdomen, the chest, the pelvis, just looking for any kind of nodules that already exist there. Sometimes that includes a PET scan, looking for lymph nodes or anything that's lighting up in a way that's suspicious, that looks like there's something growing that shouldn't be there. In women, sometimes this involves a pelvic ultrasound. In men, it may be a scrotal ultrasound if we have suspicion that there may be either an ovarian or a testicular tumor. And then if we see something suspicious, then oftentimes we will biopsy it, because the best way to identify something is to look at it underneath the microscope, oftentimes, if we don't have markers in the blood. A lot of people are very hesitant about lumbar punctures, which I understand, but I just want to put people at ease in that it's a simple procedure and give a little bit of what to expect if you've not had one before. So oftentimes we'll have somebody either lying down or seated. If you've had an epidural with childbirth, it is not dissimilar from that. But the idea is that we place a small needle between the spaces in the vertebrae in order to get CSF. And overall, the procedure should not take longer than 30 or 40 minutes. We numb the area. You may feel some pressure, but overall, it's a relatively benign procedure. A few other pieces about the experience for the patient. So immune therapy may or may not be initiated right away. If somebody comes to us and they're very disabled and there's a number of very concerning or symptoms, then perhaps we would start somebody on some kind of immune therapy without knowing what the diagnosis is. But in some of these other patients where it's not so clear, we may want to get a confirmed diagnosis before starting anybody on some kind of immunotherapy. There is symptomatic treatment available. For instance, our patients who have a lot of spasticity or stiffness in their legs, there are some things that we can do for that. Similarly, for tremors, there are treatments for those symptoms as well. But I want to highlight that that's not treating the underlying disease process, but rather the symptoms of that disease. And then we've talked a little bit about referrals, but just want you to know you may be talking to one doctor and then referred out to 3 or 4 different specialists, whether it's therapists, whether it's movement disorders or sleep medicine, psychology. You may kind of have a team at your disposal by the end of your journey. And then once we have a confirmed diagnosis, we start to talk about, immunotherapy on top of either chemo or surgery or whatever the appropriate cancer treatment would be. A couple points about spasticity. We have a couple medications that you can take orally, baclofen, tizanidine, if somebody's having very focal spasticity affecting one part of the leg or one specific muscle, then sometimes our friends in physiatry or PM&R can consider Botox injections. And then again, this is just really highlighting that specialized care, the importance of rehabilitation. So getting folks into speech therapy for swallowing, issues with diplopia, we can bring in our colleagues from ophthalmology, but we can also talk about patching and trying to alternate patching so we don't lose too much vision. Things like mobility aids, it's always, a challenge to, be independent in walking and have to move to using a cane or a rollator. That can be a challenge, but for safety, it's important to make sure that patients have access to, whatever they need to keep them safe at home, and also allow them to stay at home and be independent as best they can. Again, if tremors are impairing, movement disorders can be helpful. And then I'll talk a lot more about physical therapy and occupational therapy a little bit later. One more clinical case just to kind of show the breadth of how these cases may turn out. So this was a 53-year-old woman. She had 2 weeks of dizziness, ataxia, and then blurred vision. Initially, she came to the emergency room. She was assessed by the physicians there and then discharged with physical therapy. She was told that she had BPPV, or a disorder of the inner ear. But 4 months later, she discovered that she had a new breast mass. She did the appropriate thing and went to see her physician. She was diagnosed with invasive breast cancer. She underwent a mastectomy, but then 1 month later, she continued to have ataxia. She was now increasingly unstable at home. She was falling frequently. Then she developed slurred speech. So she came to the hospital, and now the neurology consultants and the team there, after realizing she had this new cancer, she had this new symptoms, they admitted her because they had a high suspicion for a paraneoplastic cerebellar degenerative process. Her initial MRI was normal. She got IVIG while she was in the hospital, despite, not having necessarily the antibody at their disposal. She had now had a cancer history, so suspicion was much higher. Serum tests eventually showed a positive anti-EO antibody, but I want to highlight that this takes 2 weeks to come back. So this may not be information that's readily available to you or your team right away. She was discharged with physical therapy. They tried a second trial of IVIG, but it wasn't helpful. Given that she continued to have worsening, oncology actually started her on chemo, given concern for micrometastasis. So she didn't have any identifiable breast cancer, but she continued to have symptoms of this paraneoplastic disease. So she was put on additional chemotherapy, doxorubicin, cyclophosphamide. Then she was put on trastuzumab. Unfortunately, 7 months later, she required transfer to a nursing facility. She was having some new cognitive challenges, and an MRI showed a new area of inflammation. So for this case, her symptoms were very, very consistent with a paraneoplastic neurologic syndrome. It's reasonable to trial immunotherapy while we're receiving the confirmatory testing, but unfortunately, some patients don't respond as well to immunotherapy, even with combined chemo. Some patients may continue to decline despite aggressive treatment, which is why it's so important in patients who are having functional declines to rule out cancer recurrence or incomplete treatment of an underlying cancer. So I just wanted to highlight kind of the breadth of how some of these cases may look. It's not one size fits all. It's not always the same kind of direction that we all go. But here's a couple approaches to treatment, at least from the immunotherapy side. Chemotherapy and cancer treatment is going to, of course, depend on whatever the underlying cancer is. So we know that early therapy is important for both autoimmune and paraneoplastic disorders. We believe that early therapy does appear to improve outcomes. The idea is that we have this non-restorable stage of cerebellar reserve, or basically how much your brain plasticity, how much your cerebellum, or those balance centers in the back of your brain, is able to bounce back from an injury. And so if we're able to, get started on medications and start doing immunotherapy as well as chemotherapy, cancer treatment, before we cross that threshold of non-restorable change, then the idea is that we have a much better looking clinical outcome. Whereas if it takes a very long time to start treatment, then it can be more challenging to restore function than it otherwise would have been. It can be logistically challenging, though. Like I said, these antibody panels take multiple weeks to come back oftentimes. And while that's not necessarily a significant enough time to really, change prognosis, it can still be challenging and frustrating to be waiting to find out, what the best course of treatment is. I wanted to highlight that there's really no formalized study or formalized clinical trial for paraneoplastic cerebellar degeneration. We use a lot of our translational evidence from the autoimmune sphere in how we target this. And of course, much of it is related to cancer treatment, either surgery or chemotherapy. The idea is to, again, remove that trigger that's causing the issues. But we do think about reducing the autoimmune response, suppressing that immune system and the immune system that's attacking the cerebellum and our balance centers with things like immunosuppressive medications, whether that's steroids or IVIG, rituximab, cyclophosphamide. All of these things have been used and show varying degrees of helpfulness. Just a couple quick details on this. So in paraneoplastic neurologic syndrome, so we see that using IVIG, 12% of patients in one study improved, whereas 53% stabilized rather than getting worse. Trying to translate some of this information from things like stiff person syndrome, 11 out of 16 patients who got IVIG showed functional improvement. They walked more easily, they had fewer falls, and they were able to perform more work-related tasks. Again, this is largely translational from some of our autoimmune conditions, but we do see that at least in some of our paraneoplastic populations, some stabilize or improve on IVIG. This is just a couple comments about mostly cyclophosphamide. Plex is mostly used kind of in the acute condition if somebody is hospitalized, but 50% of patients who received chemo or cyclophosphamide with Plex had a positive response or did not continue to decline. And then we have a small uncontrolled trial in anti-HU, anti-YO, where 3 patients improved with rituximab, greater than 1 point on the Rankin score, which again is just a measure of functional ability and independence. Again, wanted to highlight kind of the patient experience for you all. Maybe some of you have experienced this before, but if you haven't, when we talk about things like IVIG, this is pooled immunoglobulins taken from donated plasma, essentially. These are infusions that can be given in a hospital or in an infusion suite, sometimes require some degree of Benadryl, some kind of pre-treatment prior to getting it. But it can be done in an outpatient infusion suite, not necessarily always in the hospital, but if you're admitted for symptoms, it is one of the things that we turn to. Plex is a little bit more complex. The idea is that it takes your blood, runs it through a machine, not fully dissimilar to dialysis, but runs it through a machine to kind of clear the antibodies. At our institution, that's done with a central line, so a larger line that's placed kind of in the neck, but at some institutions that can be done peripherally as well. Then we have steroids, which this is mostly, I'm sure everybody's familiar with steroids. It can be done orally or through an IV, and this is usually kind of in the acute phase. So if somebody is acutely worsening or when they initially show up, this is something that we'll do on a temporary basis. Then things like rituximab and cyclophosphamide are more intense IV infusions. Rituximab targets B cells, cyclophosphamide targets T cells, and then these are more longer term acting agents. I'm going to hand the baton over to Dr. Abbatemarco to talk about some of the translational work that exists in the autoimmune realm and how we can adapt to that for our paraneoplastic patients.
I love it. I really appreciate it. And I just want to encourage folks, as we're going along, this is about you guys. Please throw in questions in the chat, in the panel, in the Q&A session, and we'll make sure that we do our best to answer them. I can try to answer as we go along. And then I know that we know that this is a really well-informed group. And so we've talked about some of the challenges. Dr. Page did a great job of talking about challenges with diagnosis, how we employ some of our treatments that we don't have great data for. And so what does the future look like? And so I wanted to help highlight that one, we don't have active clinical trials just in this space. So if you just looked at clinical trials within paraneoplastic cerebellar disease, nothing formal, but we've always borrowed from other subspecialties to learn about how to utilize medications. And so one of these things that there's actually 2 ongoing trials for autoimmune encephalitis. One's called CLO Extinguish, are 2 major clinical trials going on in North America, looking at very specific immunotherapies, similar to kind of how rituximab is formulated. And again, I think we'll be able to extrapolate some really good data from there. It's coming out over the coming years, so hopefully wrapping up recruitment over the coming year or so. But there are some other kind of future things that have been used, again, in other autoimmune diseases, borrowing from other fields like rheumatology, that I wanted to maybe talk about as well, that give us some further hope about these. So again, we have 2 clinical trials in non-paraneoplastic cerebellar diseases that we're going to try and kind of borrow from. But then as we've kind of gone along in these neuroimmunology space, when the immune system is off, is there an ability for us to hit a reset button to say, hey, can we start with a clean slate here? And so 2 things that have come about. A stem cell transplant, which is commonly used in cancer patients if they have lymphoma or other kind of related blood cancers. And we've seen this, specifically maybe in MS is a really good example where we can take this procedure, hit that reset button, give the patient back their kind of stem cells, and it seems to grow back in a non-inflammatory way. And we've seen some data, maybe within stiff person syndrome, that can cause cerebellar ataxia to have actually some response. This is a big procedure. In our institution, it requires a hospitalization, so this is intense. There's some new technology that's actually being employed right now as well. We've seen some success, small numbers, and again, this is still very much in the research realm, but we want to highlight some future. We want to give people this optimism that we are going to move beyond steroids, IVIG, rituximab, cyclophosphamide as we go forward. So this is something called CAR-T, and what it means is we take out patients' cells and we re-engineer them in the lab to make them a little bit more potent, and they're able to attack and go into the inflammation that's sitting in the brain and get rid of some of that. And so this is something that's specifically being done, stiff person disease, multiple sclerosis, and other related disorders. And the goal is this. I know this is a busy slide, but this top part, when we talk about the probability of remission and immune reset, right? Can we get rid of all that inflammation, not just kind of taper it down with the medications? You can see some of the medications that Dr. Page mentioned, like rituximab, is over here. Our goal is to get up here, highly effective, breadth of depletion, a hard reset. And so again, we have some CAR-T, some stem cell transplants, and so there are some opportunities here for us to really make a big difference and do it totally different than we have been in the past. So while, yes, not a direct clinical trial in this space, we have the ability to kind of help this reset. And I just saw a question in the chat said, is stem cell therapy described as HSCT? And that is stem cell transplant. That stands for hematopoietic stem cell transplant. And all that means is where the cells are coming from. So this autologous HCST is the same thing as a stem cell transplant in kind of layman's terms. And please keep throwing your questions in the chat. This is what we're here for. This is about you guys. We're going to hopefully wrap things up in the next couple of minutes, and then we're opening up totally to any questions you have. I'm going to pass the baton back to Dr. Page, and then we'll go from there.
All right, so just a couple kind of fun, exciting things in the realm, things we're doing at Mellen Center, and our physical therapists are really leading the march on. So this is an interesting case. It's definitely a unique use of this technology. So this patient really had a goal of being able to walk around unassisted without using a gait device like a rollator. So they went back and forth trying to troubleshoot, how can we do this? And most of it is the concern about supporting yourself being in an environment where you can safely fall. And that really improves confidence. So this patient was able to achieve assistive device-free walking, walking more freely, able to follow commands without having to use a rollator. So I think really just a fun, kind of interesting use of like creative technology to, get those goals, get this patient able to walk and work on their confidence with walking independently. So this is more of an interactive gait training. This patient is using a program on the treadmill. Again, this can be helpful with helping with gait training. You can see they're able to interact with the treadmill to kind of work on their balance as well. One thing I really wanted to highlight here was our Karen system. So not only is the system interactive, but it actually responds to how our patients are performing on the task. So it's task oriented. It allows patients to get a little bit more real world applications for their therapy. So this patient here, she's working on balance, but there's other tasks in which she has to start and go, lift her legs, and then kind of control her body in ways that maybe typical physical therapy would not address. And again, it uses feedback. So it uses the information about how well these patients are performing to give them new tasks and adjust the tasks in real time, which I think is very exciting and offers a lot of hope for our kind of rehabilitation for patients moving forward. So it's really exciting to see how all of this changes and, progresses over time. And then here we have our robotic exoskeleton. The idea with this is, we're still providing safety and support for our patients, but this really helps patients achieve better truncal control. So our patients able to support their trunk all on their own. The exoskeleton is helping with movement of the legs. But it really, is improving some outcomes, at least when it comes to falls and truncal control, although, more work is needed in this realm. And then similar here. So again, just supporting the legs, allowing patients to work on some of those other muscles of standing that may not be addressed by typical physical therapy. So a few just final points before we move on to questions. I want to make sure that you all have plenty of time to ask us whatever questions you have. It's all about you. But as you all know, paraneoplastic cerebellar degeneration, it's an immune response that's triggered by cancer cells. So important to keep cancer kind of a concern on the clinician's mind. But then there's a subset of patients who improve with immunotherapy along with cancer treatment. Though there's no clinical trials that have been performed in this realm, there's a lot of hope with what we can do with translation, as Dr. Abbatemarco was referring to. I think there's a lot on the horizon here, and a lot of it is translatable for this patient population. And then both things like multidisciplinary care, making sure people are connected to sleep medicine, movement disorders, psychology, all of their therapy teams and rehabilitation are important for recovery. And there's a lot of exciting technological advances in the physical therapy realm. This can both aid gait coordination and promote independence in our patients. So I think we're really excited about what the horizon holds, and we're happy to answer any questions that you all have.
Thank you so much, Dr. Page, Dr. Abbatemarco, for fantastic presentations. Let's jump right into questions. The first is, how do you compare and contrast IVIG and PLEX? And a follow-up question to that, does PLEX go by any other names?
I think this is a question that comes up in neurology not infrequently. IVIG, the idea is that there are antibodies that bind up antibodies that we think are causing issues in the blood, whereas PLEX, it takes your blood out of your system and then cleans it. The thought is that IVIG is a little bit easier to administer. So going in for an infusion is a lot easier than going in for, a central line placement, going to have this whole process. But realistically, the method of action is very similar. Dr. Abbatemarco, I don't know if you had any more specific thoughts on that from a paraneoplastic side.
Totally agree.
And then just a quick question. We've had a few people ask if this recording is going to be made public or if there's something they can go back to afterwards. Yes, it will. It'll take our team about a week to process it, but this will be up on our YouTube page. And we're going to have a landing page with a collection of resources for folks with paraneoplastic cerebellar ataxia in the near future. So stay tuned for that. So our next question, is it common to have a positive paraneoplastic test result after several years of negative annual test results?
I'm going to defer that one to my specialist here.
But we could do tag team. It can. I think we kind of highlighted how these diagnoses can kind of come back with Dr. Page's kind of two case examples. If patients start having worsening of their disease, we are worried that sometimes a cancer can happen, can kind of reoccur in the background. And so we need to be mindful. And again, that team-based support, right? Following with our oncology team, along with neurology, to make sure that we've got all of our bases covered. I will say that we try not to like zoom in too much on just one test result. When we talk about an antibody test, they have challenges in the lab. And so making sure that it's in the right testing environment and we interpret that correctly is really, really important. But I think when we hear that coming back, we're worried about a cancer coming back. And so we've got to redo that evaluation and make sure our oncology team is on board.
And as a related question to that, you already answered this by text during the talk, but just to bring it up again, is it common to have a false positive for paraneoplastic cerebellar degeneration?
Yeah, I think it's directly related, right? We can definitely, lab tests, just like any other test, are not perfect. And it's very rarely that one data piece, a lab test being one of them, is going to give us the whole answer. Like we try to keep that big picture look. And again, Dr. Page did such a nice job talking about patient symptoms, the background of the kind of cancer that they're having. What is the MRI, spinal fluid, blood tests, other tests that are showing? And so keeping that big picture look, that's what we're doing in the clinic. I know it seems like a lot of hemming and hawing, but we're trying to put together all those different puzzle pieces to make sure that that diagnosis is correct. Because if we give the wrong name to it, we're never going to get the right treatment on board.
So need to be careful, go through each step. That makes a whole lot of sense.
Definitely.
And then we have a question here. Can Keppra cause or contribute to cerebellar ataxia? I believe this is an anti-epilepsy medication. Could you comment on this?
I don't know that there's an association between those two things. Sometimes, imbalance or dizziness could be a side effect of that medication, but I don't think when we're talking about paraneoplastic cerebellar ataxia, we haven't seen data linking those two things.
Very good to know. And then a next question from an attendee. Can a person with brain cancer end up getting paraneoplastic cerebellar ataxia?
So certainly possible, but I want to just highlight that our paraneoplastic diseases are from cancers that are not CNS cancers or cancers within the brain. I don't know, Dr. Abbatemarco, if you had other thoughts on that one, though.
It is. It's actually a really good question. You would think, right, we're dealing with the brain. Why are we talking about all these different things? But primary brain cancers do not usually do that. I think it's a little confusing because sometimes lung cancer or other cancers can go to the brain. Those can still be causing a paraneoplastic disease. So it gets into a little bit of nuances. But when we think of a primary brain tumor, and I think Dr. Page used these terms like glioma, meningioma, these common cancers do not cause paraneoplastic diseases. It's usually cancers elsewhere in the body that really stimulate the immune system and get us in trouble. But again, it's a little bit of a nuance. I hope we did a good job. I did a good job describing that.
No, that makes a whole lot of sense. And we have a couple of related questions that have been asked. And you touched on this in your presentation earlier, but if there's an underlying cancer or tumor, is it common that that gets missed at the beginning of all this testing?
Go take it.
It certainly can be. It certainly can be. We try not to. If we have a high suspicion for a paraneoplastic disorder, we do everything that we can to screen very thoroughly, including a PET scan, which is usually quite good at picking up underlying cancers. But certainly, like in this case that we saw, it took us a couple months to identify that there is a lymphoma. I don't know if you had other thoughts.
I don't even know if I use the word miss. It's just really hard to pick these kind of things up because they can be really, really small. Having that team on board and having regular discussions and follow-up, that's just a part. Like time is sometimes the other puzzle piece that we talk about in clinic a lot. So trying to put them all together, but it takes a little bit of time, and it doesn't mean we give up.
And speaking of those different symptomatic puzzle pieces that you need to put together when creating a diagnosis, we have an attendee who's asking, what are the main differences between paraneoplastic cerebellar degeneration caused ataxia and some of the more common forms of maybe genetic forms of ataxia in terms of symptomology based on how patients are coming to the clinic? Or does that give you clues about what might be genetic, what might be other forms of acquired ataxia? What are your thoughts on this?
So I will start with one thing is onset. If something's been present since birth or been ongoing for years and years, I think it's less likely to be a paraneoplastic cause, where if something's a relatively new symptom, and over the course of a month or several weeks, it's really gotten fairly bad, then we're more worried about a paraneoplastic process. But Dr. Abbatemarco might have a few more thoughts on if there's other symptoms that he looks for in his clinical.
I love that. I think the speed at which the symptoms that can be helpful, but it's honestly can be very difficult otherwise. These are all affecting that same organ, and so it produces this wide array of symptoms. And then I don't need to tell this audience how important the cerebellum is in terms of every aspect of functioning, from cognition to coordination to this. It's like the circuit breaker of the brain. So the vast symptoms that it can produce make it hard to just use that. But the speed in which it comes on can help us. So I can't tell you how humbled we've been in clinic, where cases don't fit that traditional bucket. And so again, it takes a little while to identify.
Thank you for explaining that. Our next question comes from an attendee who asks, have you seen HSCT help with paraneoplastic ataxia? And have you seen Medicare cover this form of treatment for folks who have paraneoplastic ataxia?
Yeah, so it's two really good questions. In terms of paraneoplastic disease, I guess it's a little bit of semantics. Sometimes we could use the oncology piece can treat cancers with a stem cell transplant, but not usually as its primary treatment goal. And insurance coverage is really difficult. It's really difficult for any of these meds because they're very expensive, but this one is particularly, it requires a really strong oncology group that's able to kind of discuss that and does not always go through. But when we talk about paraneoplastic diseases, we talk about getting rid of the cancer first and foremost. Like our whole world revolves just around that. All of the secondary things happen after that. And again, I think Dr. Page and I were just hoping to highlight that there is hope beyond just a couple of medications that we've been using for decades. This whole landscape is changing and changing very fast.
And that is very exciting to hear the
It
progress that's
is.
being made within this research.
Yeah, and beyond in all kind of forms of inflammation of the brain.
100%. We have another question specifically around trials that are ongoing right now. So we have an attendee who asks, there are some trials ongoing using psychedelics like ketamine and TMS to treat brain injury by increasing neuroplasticity.
Yeah.
Do you see any potential for these kinds of treatments for paraneoplastic cerebellar degeneration?
I love that question. I am not, we've seen this used in other forms like our psychiatric colleagues, our pain management colleagues. I think symptom management wise, I think this could be a huge benefit. We've seen amazing results in terms of pain, other kinds of forms of depression and things. I haven't seen it specifically in terms of like recovery of the cerebellum. And I think we mentioned this, and again, this group knows this. The cerebellum seems to be exquisitely sensitive to any insult. And so how we kind of help with that repair, that's been a harder thing for us to figure out. And so I haven't seen any specific data there suggesting it helping with that kind of nerve recovery, but helping other aspects of the disease. I think we've seen amazing results.
And then about these kinds of therapies again, you mentioned virtual reality as one of the interventions that you are exploring with your team. Could non-medical virtual reality devices be used for physical therapy exercises at home if the type of setup that you showed in your presentation isn't available at someone's local outpatient facility?
So while there is research using things like Oculus Rift, those sorts of things as physiotherapy, that sort of research exists. I just want to provide a little bit of caution because oftentimes these at-home virtual realities may take away your vision and your awareness of the outside world, and that can be very challenging. If you have ataxia, it can make it worse. So I just, from a safety standpoint, I want to make sure that you're working with your physical therapist to make sure that that's something that's safe to do if it's something you're planning to do at home, just because the difference between things like the Karen system, where you're able to visualize everything in front of you, you're able to see your own body, and that provides you balance. Things like the Oculus Rift takes away that vision aspect and can make it actually more challenging to balance. So just work with your physical therapist because it may or may not be safe. That's all.
So good to know, proceed with caution. And then one of the things you alluded to in your presentation was how after the treatment of the underlying cancer, some people's symptoms ameliorate to different degrees. So we had some questions from people in the Q&A wondering why this difference might be, how some people may have better recovery in certain situations, or they may have symptoms linger after multiple years.
Yeah, I think probably a multifaceted answer. It may be related to the underlying antibody that's the culprit, could potentially create a more severe disease process, versus if there's more of a delay in the treatment, that could potentially also reduce some of your cerebellar reserve. I don't know what you've seen, Dr. Abbatemarco, in kind of how that changes people's outcomes and prognosis.
I think that's a really good summary. Yeah, I don't think I have anything to add.
And then we have time for one last question. Our primary focus here today has been on paraneoplastic cerebellar degeneration. Are any of the treatments that we discussed today helpful for other forms of ataxia in terms of that cross-disease impact?
I'll defer that one to you.
We do not. And I think it's the importance of the diagnosis, which is why we spend so much time on it in this talk. No field is moving faster. Maybe we're the second fastest field because genetics is moving even faster. And again, I know this group is well informed, but the movement there and the different technologies being employed will be really helpful. But we don't usually think about using immunotherapy because there's risks with these things and we always have to weigh them.
Of course.
In general, we don't think that immunotherapy helps with the genetic piece.
Would the physical therapy, though, and those sorts of exercise interventions, would that be applicable for other forms of ataxia?
100%. That
Well,
holistic treatment is so important. And again, organizations like this, maybe it's a perfect way to end, but this community and having people, and this is the kind of elements that, that are shared between all of these different diseases.
Well, we are ending right on time. So Dr. Abbatemarco, Dr. Page, thank you so much for spending an hour with us and telling us more about paraneoplastic cerebellar degeneration. We really appreciate your time and your expertise.
Thank you. It was a privilege. We appreciate it.
And thanks to all of you who spent the last hour with us. I hope you learned something new and something interesting about paraneoplastic cerebellar degeneration. And wherever you are in the world, good morning, good afternoon, good evening. Have a wonderful rest of your day. Take care, folks.